you, Dr. Cole. It's very nice presentation. Last but not the least, we have Dr. Kang Ting, and will come to the stage and talk about his presentations. And so please allow me to introduce Dr. Ting, and he is a Harvard graduate and got his DDS training and DMS training from Harvard, and also was former academic senate professor and a founding chair in the Division of Growth and Development at UCLA, with joint professorship at School of Medicine and the School of Engineering. So Dr. Ting right now is also our adjunct professor at Forsyth Institute, and we are very honored to have you here. And Dr. Ting has many expertise, I would say. And but one of his right now he's going to present is about his translational and the tissue engineering research. So Dr. Ting's research has received over 6,000 citations, and also has a 146 peer-reviewed journals, and right now has over 78 applied and all issued patent applications in US. And also Dr. Ting has received over 25 million NIH grants. And one of his research is collaborate with NASA, right? And sending the Neo-1 mice and to the space. I think it's a lot of people, scientists' dream to work with NASA. And you realize you make your a lot of scientists' dream come true. So please, Dr. Ting.
First of all, it's the last talk today, and I promise I will not talk about molecular biology or any research in that aspect. But I would like to take a minute really to say something about Dr. Maurice. I think all the Harvard graduates here, Dr. Moon, Dr. Ahmed, Dr. Peter Nunn especially, will have deep experience, owe a lot to him. If anything I forget, please let me know, and please join me to pay our respect to him. Dr. Maurice is a true giant in orthodontics. I was at Harvard in 1986 to 94. I had the luck to listen to his lecture as a dental student. I remember many things about him. First of all, he always asked his first-year residents to go to the Boston Museum of Art, look at the famous painting portrait, and draw the facial profile. He's really one of the first few persons to actually pay attention to the facial profile. And remember that at that time, and Brian Moran, of course, I'm sorry to mention you, and he's really at that time when the very few people pay attention to the facial profile more than just dentition. And that's one thing you remember about him. I mean, a second thing I remember about him is about his true impact research at that time on mixed dentition growth development in dental arch and width. That lays the foundation for a lot of us in mixed dentition treatment that actually save a lot of extractions from kids and preserve the profile. I think his articles and his research up to date is still the necessary reading material for us to read and to memorize. I mean, as every single program that move forward, right? He's a true artist, scientist, clinician, and teacher. And I'm here so grateful to Forsyth that actually I'm kind of embarrassed to say that as a Harvard graduate, this is his first symposium after all the contributions he have done for us at Harvard, our graduate, and everyone in the field. So thank you, Forsyth, for your help. And I know that he's closely related to you to take the initiative to really for us to thank him for this great event. Thank you. Second thing I want to say is about more interesting about Dr. Maurice that make us think about what we're doing today. One thing when I was in the program, I remember he banned straight wire, straight bracket, right, from our clinic. We are only allowed to use two systems, back and edgewise. Back really challenge about your biomechanics, and edgewise is something that probably none of the residents now they know how to use it. It's yet to be in the first order, second order, third order bands. You get callus in your fingers in the first 2 weeks when you stay every day downstairs in the basement, right? I mean, nowadays when you heard about it, you find it's absurd. We talk about productivity, we talk about all these standardizations, yet he talked about individualization of each person's beauty. He believed that no teeth should look the set should look the same. And this is what we learned it from. Although it's a lot of pain, but I think it gave us a lot of contribution and education. And I always wondered if today, if you look at what we have talking about today, how would he say, how would he feel? It's become very interesting when you think about it, right? So I think those are the very interesting thing that about Dr. Maurice that would like to say. Anything anyone want to add about Dr. Maurice? So if not, let's move on to our talk. Okay, as I mentioned, I promise I will not talk about signaling molecule. I was kind of in the last minute, but I want to talk to you as a old timer, as a orthodontist, graduated in '94. Now I'm 56, right? I taught for over 26 years. I have no experience about all the new thing technology we've learned in dental school or in our program, nor have I taught anything about aligner, anything. So I want to talk to you about how I understand from learning from Dr. Ben Wu, one of my best friend and mentor, about what material is about, all this aspect. So I regurgitate to you about what I have learned. I'm not pretending that I'm the expert. There are too many experts in aligner already. But I want to tell you just as an individual orthodontist, academician, what I know about liners and what's my concern and what's my worry. And Dr. Wu and I, we worked over 20 something years on tissue engineering. We have done a lot of grand publication in high impact journals that we can talk for the whole day. But a few years ago, I sat down with him. I told him that, Dr. Wu, I need your help. I need you to lower your level from the space scientists, or the self-healing polymer, all those kind of things, to help us our field, to really help us standardize and characterize the clear aligners. And we submitted the first proposal and the only proposal funded center grant by AAOF. And again, I want to appreciate Dr. Watwa. Did he leave or he's still here? Yes, he was the one probably, I was not in the committee because I have to step out from the committee of the conference, but he gave the big support, felt that it's so important for us to understand. And Dr. Wu able to spend his time to help us, even though we know this is nothing like scholarly, scientific, creative that we have finished, but something we needed. Does he mention? Because we just don't have any standard, right? Why is this a problem? As we all know, nowadays in other young kids clinic, over 50% are using aligners, right? And this is being emerged technology. People are using it, but really, how much we know about this technology versus how advanced we are in using them on our daily practice? Are we doing a service to the patients or not by not understanding how it works? So how well do they work? We all know the numbers, right? Based on what we understand, based on my skill experience, we have a lot of retreat. We have a lot of extreme rotation that we couldn't do. And most importantly, extraction cases, right? That's the most hard thing to do with aligners. I think a lot of people agree that we should not use extraction casing aligners. But why is that, right? First of all, another failure relates to multiple things, as Dr. Wu and I will discuss and understand as a clinical person. Dimensional change, right, for various reasons. Lifting and disengagement, what we see all the time. Stress relaxation, we can talk more about that. Yielding, creeping, wear, cracking. Dr. Wu talk about the fracture and chemical and biological degradation. That is Dr. Wen Yanxi and Dr. Ting Xi's expertise. I will not talk about that. All this adds into factors of failure of aligners. But what's the fundamental problem that we have? Is most of us, not all of us, of course, especially at the mid, including my residents before, we lack an understanding of the basic material science and how it translates to biomedical tooth movement. For all the chairs, I don't know how many lectures he gave to residents about polymeric material, aligner material, how it works. For my program, we were trying to start it this aspect like right before we left, but unfortunately was never passed down. So our residents or graduates that are using this material without understanding that it's like an MD giving a drug. They don't understand the pharmacokinetics. They don't know pharmacokinetic or pharmacology. Yet they're giving the drug. Take this drug. It'll help you. But how? I don't know. How can you be an effective doctor when these things happened, right? Therefore, I'm talking about how much I know as a pure plain molecular biologist and tenured professor, as a common person. How much we know about this? First of all, simple thing. We know material, they are different structures that as a complication of different aligner we use, right? And we don't know what they are. Does anyone know what Invisalign G7 is about? What material is made? Can you raise your hand besides Ben? I don't think people knows, right? And here is diagram show that all different material people are using, but we don't know. Just like almost you give a drug, what's the difference between Advil and Tylenol? I don't care. Take the drug. That's not how it works. Or there's a cancer drug, anti-cancer drug, or antiviral drug. It doesn't work. We have to understand this basic thing because we relate closely to how we're going to treat patient. And today I'm trying to make an understanding of how this can be related. I may be wrong, but it's what I try to do. So objective today, want to review the concept from Connecticut, stress strain of thermoplastic material. What's the creep and what's the most important thing is the stress relaxation and anisotropic property that Dr. Wood explained a little bit. And application, how do we use this difference in property in terms of changing how we treat patients, how we staging our patients, staging the case. So this is the diagram. First thing I want to show. I mean, I was a little bit surprised to saw initially. This up is the nighttime wire, perfect wire made, right? We have the A phase, the M phase, and we have a long range of elasticity. That's what we do. When rotation, what do? Tight it in, ligate it tight, right? Let it go, let it go, let it move. Down there is more representations of a polymeric material where you have this very, very narrow range. Let me get my, 1 second. My own bright. Doesn't work either. Forget it. Use my finger. Excuse my finger, please. So, and this is something we have to work with, right? When you look at that, and then everything else here become a shady area where it becomes creep aspect, stress relaxation, the unknown area where polymer material gets into, and in practice, besides here, we a lot of time aligners to work on this regions. Unfortunately, that's what we do. So here shows you aligner is very different materials, very different from metal wire we use, from different mechanical, from biomechanics we learn. Stress strain, we all know this from very well from based on the classic textbook from UConn. Stress, force per area, right? I'm sorry. Strain, the formation of dimensional change, right? So far. And however,
I'll give you grades afterward. Okay?
please do. Actually, Dr. DeFranco taught us biomechanics for your school, and I got 100 points out of 200. So it's again, it's relative. Don't look at the absolute number. So here we look at the stress strain curve. It's a polymer material. This is so crucial because this aspect we don't understand. And most complicated part, this component. What is going on here? London material, number one, is not metal wire. They are viscally elastic. That's something I learned. Visco material is that we apply to a force, it starts to form, and we start the force, it remains flat, right? Here is the elastic material. We drop the force, it remains flat. Visco actually is a mixture of this. So this is an overly simplified diagram that we know. But however, based on this, we can tell we're talking about a different set of mechanics here. As Dr. Wu mentioned about what's so special about it. Narrow region work besides that, you point the formation of curve. We have both the stress relaxation happened, stress degree, and also with deformation, which finally ruptured. Oh, so finally it ruptured, right? That's the hard part about how to use this. And there's a necking issue that actually we can go finer into molecular biology in the future, but basically it happens with the specific material property on semi-crystalline versus amorphous phase. So Dr. Wu mentioned about this thing. We have huge problem. We start the study because company will not share with us what they have. I mean, will you ever see MD prescribe a drug without knowing what the drug's about? Use it, right? It's good for you. It's good for you to be happy. Happy pill. but that's not what we do. Why are we accepting this kind of issue? But Dr. Wu is smart enough, and I'm lucky enough to learn there are always ways we can be better than they are by looking at using the machine and different ways we can analyze it, right? We can cut a small piece from the already formed material and look at the biomechanics, look at them, compare their monograph difference. And we talk about physical elasticity. This is what we happened. When the creep happens, we have deformation under a constant stress. That happens when the patient is wearing the aligner for long term, right? So here shows you, this is the classic textbook from Dr. Prophet, as you know, the amount force required, tipping, rotation, and it all has to occur in this region. Once you passed it, you got deformation. And no matter what you said about aligner, how popular they are, the fact is that material property is just inferior to what we have done if fixed applying to metals. Metals, we know nighttime, we have stainless wire with different wires, right? And what we want is an ideal aligner. It's just standardized what we have. I don't know name, please. Okay, so, but this is what we want. This is what we have. And no one ever told us, right? As time goes on, stress dropped, and we just keep on using aligner, use it for 2 weeks. Why 2 weeks? The one day it dropped already. What's the random number on this thing? No one ever tell you. I thought we mentioned about that we'll be able to measure much a macroscopic and microscopic now. And all data we're gonna have, hopefully we'll publish them. But this is the creep formation. Creep and stress resistance are related, but they are not the same, okay? Creep describes time-dependent deformations. You apply a force, you get a deformations over time. And that's the biggest problem we face really with the aligner material. This ideal curve, initial strength, you get a typical one, and then you get the deformation, and they get fractured by the stress. Okay, and this is the problem, and it's become more complicated, as Dr. Wu mentioned before. Time, temperature, all play a major role in this thing. Oral cavity, take it out, what you eat, what you drink, right? So creep also relate to the potential cracking, and it's a really unique, not to metal wire, but to aligner polymeric material, right? Because of the viscoelastic property. You can see that initially you get a strain. When you let it go, you get initial elastic recovery, and then become unrecoverable. You get deformation, right? And how do I interpret this idea, this issue? I don't know. Have you ever taught your own residents that when your aligner is out of track, let's go back to keep all the aligner, but if aligner number 10 it seems to be out of track, you go back to number 8 or number 7, redo again. Have you learned that before? Like keep your old aligners, and if it doesn't work, go back and try to go forward again. And that we learn is not good. The reason why is because you already have creep happen, deformation occur. But why is that the company make a lot of circuit lecturer tell us, go save the aligner, go back? You know why? Because they generate with aligner from first one to the last one. Well, it's also you ask you to finish it, right? But the ideal thing is really make course correction. Don't try to let's go from beginning to the end and then we do the correction. No, when you see something's wrong, out of track, the rest is going to be useless basically. Make course corrections. And I think those are the things between commercial sales versus what we do clinically. And of course nowadays with scanner available in the own office, we're able to do that better. So here shows you, right? When you put a liner in there, very soon you're going to have a space, and the deformation, so it cannot move well. So we just go for micro corrections instead of trying to go to the last one and then come back to a correction, do a so-called or a finishing correction, right? It here shows you the material, how it should behave. The more elastic one should release the strain, less elastic one, it should be. And that's how we're gonna look at the monogram to see how material works. Because you don't want to listen to a company that said, my materials is now we're generating G7 or G8 or G9. What is the difference? Show me the data, right? Otherwise, what's the point? They can tell you it's a G100, right? So what's the difference? And this is what we have to learn. I mean, for old timers like us, unfortunately, but great for the new people in the new program, the generation in the program, something you have to learn. Tell your chair, you want the whole course on this. This is your future. 50% of patients going to be 70% be based online in the future, right? Why can't you learn something more, right? If they don't know, tell them to learn. And then come back and teach you, or you can teach them. You may know better than they do. So here we are drawing the three-dimensional diagram. They show the complexity of the stress, time, block time, and strain. Any cross sections, when you look at them, you can see the isometric section, you can see the constant strain, what happened. So this what we plot eventually, no more two-dimensional pictures about biomechanics. This is what we have to learn. And again, trust me, I'm still learning. So I don't know this whole thing, but this, I know what we need to do. Of course, evaluation, treatment, Dr. Wu mentioned about it. Between isotropic, once we pull it down, you stretch and you pull, it's going to be different, very, very different stress, strain, relaxation, and creep, right? So don't think just one dimension, one dimensional is very different now. So sometimes when you pull this way, your rotational force or your the other axis is going to be very different in properties than what you do in one dimension, one axis. This is why Dr. Wu mentioned when you test material, it can be vertical and horizontal on both directions, right? He showed this thing, but he didn't tell you why. So this graph is very simple. Different material test, more comfortable, less comfortable, more comfortable, but more elastic modulus. Which one is better? Common sense. Comfort or more force? You know material is not going to be strong enough or for more force. But then consumer like comfort. This is why you get material claim they are more comfortable. But is that better? No. There's stress, strain, stress, yield stress, and yield strain. Again, better know higher number, the better, because store more energy before the formation and give you better material, right? Impact energy, that will explain that already, related to cracking, you don't want to, and this is actually what he just shown, right? But one thing interesting, 2D, 3D, three-dimension, sorry, small piece at the after transformation at the real situation versus what you do as a block. You can see the major difference in, even though the trend is the same, but you see the stress realization is much more severe. After time, 1 hour time, you drop a lot more. So actual reality may be worse than what they show you in the monograph. So we know as a part one material, there's a lack of quality data, right? And so confusion for all of us. I don't plan to know, just like when remember when first year, second year learning biomechanics, moment force, I think I bet half the resident didn't understand, but just not their head. This seems to be the way because it's from Burstone and from Dr. Nanda. You don't go against the Bible. But again, it's confusion. But this is really created, I mean, by us. We have to be responsible for it. That's why it's new creation. So next thing is about the clinical relevance. This is what we do as a PhD.
That's what happens.
This, hey, but I'm being honest that I don't know what I don't know. I think we all should understand what we don't know. That's number step, well, first step, right? We all should realize that. So clinically, as again, this is really my very first clinical talk in 26 years. I always talk about research, right? Cranial future patients. But this is something different because Dr. Nanda said, well, I cannot talk about my research. I have to be a consumer-based lecturer. I was thinking about that, but you said don't talk about it. No one want to listen to it. So, so I have to do what the residents like because they are customers anyway. So But still, it's important because I enjoy it. That's why I first started Wood to do this kind of research with me, wasting his time. So why is that? I mean, he's working on NASA project, okay, space, hello, here. So we talk about the main problem. 3D treatment planning a lot of time is not the same as what we see in clinic, right? Agree? This is a typical extraction case for staging. No name for the company. And you can see this perfect dentition in the end, moved by programmer in Puerto Rico probably, get a perfect and ideal occlusion. And a lot of time, if you do that, that's what we get. How many of you experienced this kind of experience? Right? This may be extreme case, but what we see a lot of time, we cannot close the space. We have tipping with the molar, angulation is totally wrong, get a deeper bite, and with the worst parts of a roller coaster bite like this, right? What do we do in the end? Go back to braces and finish it a lot of the time, right? Some people probably can handle it, some people cannot. I just couldn't do it myself. So I think the issue when you look at that, what's wrong there? Staging looks perfect. I think really we never integrated properly on staging plan. You can buy software outside to do staging, but is there an input entry about biomaterial, stress, strain, resistance curve? Nothing, right? Isn't it something you should enter the program and they give you a calculation on the staging movement is required? Simple thing, translation. It's better to have a more rigid material or soft material. What do you think? I don't know. Soft material, people tend to say is more flexible. You grab the tooth, you can move, right? Versus rigid material and more misfitting. But when you look at biomechanics, sorry, it seems to be more point contact here than this material pushing here. This potentially give you more closer to the center of resistance, right? So when you push this one, seems to maybe give you more tipping possibility. When you look at biomechanics at different angle, sometimes give you a different answer. It's kind of confusing. So FEA analysis, we work with a company and look at the rigid material versus less rigid material, flexible material. Look at the strain curve. The more rigid material give more force where? Near the cervical area, right? But the soft material give a generalized, more less focus point. So when you look at biomechanics, this one perhaps will tip the tooth better, or control the torque better because give less tipping potentially, right? So when you think about it, is it better to use more rigid material for focus on the gingiva, so give you a more force application, a shorter arm to the resistance? More elastic material may be more comfortable. It seems to be grabbing the tooth. So you think grabbing the tooth better will have better control, but may not be true because it has an issue here, right? But again, aligner apply force essentially via elastic deformation. The structural factor determine a nonlinear uneven force deformation, right? And they never really achieve a true fit. So that means no matter what you do, initial stages is almost impossible unless you do different type control, right? And is rigid better? The problem is here. Even more rigid displacement would cause what? Deformation, become out of track. So become a balance. Rigid material, perhaps less incremental change at every stage. You're looking scared, scary, Dr. Nanda.
No, I'm a little bit amazed at your knowledge of clinical orthodontics.
I know. I never showed that side self to you guys because I want to make sure that I don't want to make people too jealous. I'm just kidding. Because PhD is the next level of BS. So translational movement for molars. Let's look at that. Why is better control the transitional movement in molar? Because as you know, when you move this versus this position, you get more flexibility anterior position versus here. So in a sense, because contact area is more and all this aspect add together, molar may be easier to control, right? So what we want to do by the way, I work with a company that's not selling US, so there's no commercial interest in any selling, but just more research experience. So one thing we can think about is that how do we first, because Remember, when we do aligner treatment, when you go to a company, who treat them are the high school graduate, do the staging. You got to tell them what to do. What do you learn from basic 101 for Dr. Nanda? Control the anchor. So you want to make sure the first staging, you tip this. Before you anything, you tip the molar. Make sure it's upright. Then once you tip, forget about it because it's so rigid here, you can never tip it back. But you want to, in the first few months, tip the molar, make it upright, as upright as possible. And second part you need to do is really for canine. For canine, make sure canine is always the right position, right? And you can do different way. You can do attachment, passive or active. That's up to your decision. And we don't have enough time to talk about that aspect. And there's a lot more thing we need to learn on that aspect too. So that's what we do. Until you make sure your canine is totally in the right position before you move them, right? Some people talk about how about adding that ridge. We just talk about it. Is it good or bad? I don't know. If it's too thick, what happened? Over the area, maybe too rigid, too much stress, you have deformation, right? Right away, you're out of track. Then what's the point? Agree? So that becomes a very issue that you have to figure out what you want to do with it. And of course, one more thing you have to make sure, always do a reverse curve, right? Because you know what happened to the molar. A lot of times they get intruded, right? So when you do a point contact, you don't want to do people, oh, I have all point contact. No, on molars, premolar. This is where you're going to get intrusions a lot of time by the material biting, and this is where you want to be able to up. So here I want to show the patient. It's not my patient. It's a patient that I work with. I work with the group, and so I cannot take credit for it. It's a very typical profile that requires extraction, as you can tell, right? Biomechanics protrusions. What you do usually, patients always extractions, right? And this is what we do. So the number shows the high lower face, hypertrophic mandibular plane. So it's pretty typical what you saw in Biomechanics position case. And what we do, the treatment planning, of course, for by extractions, with alignment, anchor, all these things, we mini screw in the upper to intrude anterior so that we can reduce glommy smile and also reduce overbite, right? That's what we want to do. And here's the treatment planning. First step, always upright the molar first before you do anything. Don't think that aligner is something you can move all teeth around. Don't do that because everything, just like wire, affects each other. And material is even worse because metal wire, you can extrude out a little bit, you can bend a little bit, but those materials that volume is fixed. When you change one location, the other one can get distorted. There's already a wobbling effect. So don't do too much movement. People always feel they're going to do movement. No, that's the worst thing. It'll be slower than what you can expect. Right? You see that upright this. And then you can start to upright that and start planning the retraction, relieve the crowding. This can be done. This shows you the number, that what the degree we need to do. Just show you the occlusal view. You don't see the model upright here, but you see the number you increase against other things going back. And there's totally 36, 34 we require two refinement. Okay, so even though if untrained eye look at them, they're the same. But actually, they're very different because you need to include the material rigidity. You need the staging is different. You need to do not just staging for the computer side, also for tumor, the different phases you do. It's totally 6-something traits. So treatment progress, let's look at them. Starting, 2 months, molar upright, molar upright. Once the molar get more upright, you start the canine. Everything is very fine. I mean, you don't see this obviously, but those are the preparation you do. You don't waste your time, but this is time well spent, right? And move the canine back continuously, step by step. A very typical, of course. At a certain step, you start to intrude. You don't want to have a deep bite because remember the wobbling effect. One thing we learned always is that you don't close space on a nighttime wire. Do we agree? right? You think which one's stronger, natural wire or this thing? Of course, this is more flexible. So you don't have the same extensive wire to do retraction. This is why you always have worry about this kind of aspect. Keep on pushing up. Otherwise, you're going to get deep bite. 28 months, closing up, finishing, everything. And one thing I always get very annoyed, I can tell you this thing, is that all the circuit lecturer from aligner company, they never show you a Panarex or Ceph. Am I correct? Why? They want to hide something. So here we give you a proper number, even though it's not tweet, it's not what I like, but they use tweet, it's okay. Root Pellinson, you have to do that, right? Otherwise, why even show people a case? It's just the dentition looks pretty on photo. It's important, facial change, dental change, you can observe that. Start and finished, you can see that. But most important part, root pellism, you have to pay attention to that, right? Otherwise, you're going to fail bore. Well, they don't do bore anymore. It's like we used to do how many cases, and now it's like, what? Okay, 90% passing. So, so here we look at the start to the end, change of the facial profile, dentition change. This is what we want to see, right? We get a little bit reductions of the change, but not much. And that's why when you look at that, you know, we have limitation material. You can choose rigid versus more flexible. But then each material, you got to get a balance on your, and also with your, what you do, right? The worst part you want to do is that when you want to do too much and you get out of the track movement, then everything's over, you start again. Go back to make course correction. You may have 60 trays from this company, but then at 30, you're going to go back and throw away the 30 trays. Not going to talk about the waste and environmental hazard for this material, but it's just something they don't care, but you should care, right? This is the typical concept we know. But what we've not is what we don't know again, but I'm hoping I know what I don't know are those aspects. I'm just trying to learn and just have constant meeting with Dr. Wu and try to read books and understand what they are. And I don't know how many you need about this thing. What's amorphous material versus semicrystalline? How does it affect transparency, affect Nick phenomenon? What's van der Waals force has to do with this kind of making sliding sheet, hydrogen bonding, too strong, too weak crystalline phase, right? Physical property, anisotropic, isotropic. That's something we haven't touched yet because remember when you put it down, you already create anisotropic type measurement. It's never going to be the same as you do the other dimension, right? Ductility, brittleness. How does this transformation force, just heat transformation force, affect your property, right? And the last thing, biologically, we put long-term in mouth, degradation, water height, water saturations, all these kind of things we just don't know, and irritation, everything, and of course cytotoxicity, as Dr. Feynman mentioned. And those all the aspects we don't know. Yet we're using that over 50% of our patients nowadays. Again, this just show you one more time. This is how much I know. I'm sorry if I don't know more than I should be here wasting your time, but I'm being very honest. Among all the lecturers, there are too many second lecturers, but let's be honest about what we really know, what we really don't know. I think this is my talk. Thank you very much. And again, one more time, I would like to thank Forsyth, really. I mean, as Harvard graduate, we are in debt to you because it's really the first time we really have a Maurice Memorial Symposium of all those years. And Dr. William Shi, thank you so much for doing this. And thanks to your board to approve this thing and allowed us to sponsor that because Dr. Maurice is well deserved and low deserved this symposium. Thank you.